So thank you again. Thank you for joining. So today, the Lunch and Learn, it's an opportunity, I think, to showcase some of the global health work that's going on at Children's and Women's. So for those of you who don't know, for the past few years, what is now the Institute for Global Health has been running a seed grant program for global health that's open for anyone at Children's and Women's. So we'll be hearing a bit of the work that the seed grant has funded. And we also, the Healthy Starts, we've also been co-funding one of their Catalyst grants that are focused on global health. So that was actually Liisa Holsti's project, which she'll be sharing with you today as well. So I'll just get right in. The first speaker is Dr. Angela Kaida. So she's a global health epidemiologist, distinguished professor at Simon Fraser University, and recently appointed the scientific director of the CICH Institute for Gender and Health. And she also has substantial experience as a public health practitioner and previously held a Canada Research Chair Tier 2 in Global Perspectives in HIV and Sexual and Reproductive Health. So her research program focuses on the links between HIV and sexual and reproductive health, including the youth-focused, AYAZAZI project. Sorry, I might have butchered that, but she'll be talking about that today. So on to you, Angela.
Oh, perfect. Okay, well, thank you so much. So if you can stop sharing your screen, okay, great. And then I will bring up mine. And so do you see my notes?
Yeah, it's note view.
Okay, now it's good. Great. Okay. Good afternoon, I guess, everybody. Thank you so much for this introduction. And thank you for, the Institute of Global Health for making space for us to share what we've been learning through these seed grants. So I'm going to share with you some of our learnings from the AYAZAZI RIGHTS study, which is a youth-based study that's focused on rapid investigation of gendered health outcomes in the time of SARS-CoV-2. So I hope you will be impressed by our very witty study acronym, and it builds on a study that we've been working on in South Africa for almost 10 years. It's been focused on sexual and reproductive health and rights that we were able to leverage to do a rapid assessment of what was happening in the time of COVID. So I'll just start by acknowledging that I am joining you today from the unceded ancestral and traditional territories of the Coast Salish people, which includes the territories of the Musqueam, Tsleil-Waututh, and Squamish First Nations. So because I'm talking to you about South Africa, I just wanted to start by sharing a bit of background of what happened in South Africa in the early days of COVID. And so, like governments around the world, the South African government implemented a range of different societal restrictions to help prevent and control new COVID-19 infections. So what was experienced in South Africa was actually more in the realm of lockdown. I know people here talk about lockdown, but I'm not sure that that's quite accurate. And really, there was a lot of questions around in the early days of the pandemic around whether such restrictions, they were really built on high-income country experiences, but applied in settings of low and middle-income countries, where there were vast inequities already existing in terms of employment, income, access to healthcare systems, and really some deep concerns about the exacerbating those inequities, creating disproportionate harms on key communities. And so what this figure shows us here is it's an epi curve mapped on one of the axes. On our y-axis here, we're seeing the daily confirmed COVID-19 cases as a 7-day average. Layered on top of that is a summary of the types of alerts and interventions that were applied. So on the far left side, you can see that on March 5th, that was the first imported or travel-related case of COVID in the country, identified in KwaZulu-Natal province, which is the province that our research actually ends up taking place in. And then subsequently, we see clusters of cases being reported across the country, followed very rapidly by a community transmission, as happened in most countries around the world. But from there, South Africa went on to experience the largest COVID-19 outbreak in Africa. Today, estimates are around 4 million confirmed cases and over 102,000 deaths. But given that South Africa is also home to the largest number of people living with HIV, and real concerns that an overburdened, overstretched healthcare system would be overwhelmed. By March 23rd, the South African president, Cyril Ramaphosa, announced a national lockdown, and it was enforced by the National Defence Force, which was deployed to enforce all South Africans to stay in their homes with very few exceptions. So they could seek essential medicines, they could go out to get food under very limited circumstances, or collect social grants. But from there, that was the level 5 lockdown measures. And from there, those measures alleviated slightly to level 4. But even under level 4, people were really limited from moving around. Schools were closed. Public transportation was really limited. So folks who were engaged maybe in more informal forms of employment could not move around the country or around their area. And just generally, the level of restrictions meant that most folks who were maybe precariously employed, or couldn't do the laptop work culture that many of us were privileged to do, was just not possible. And so those levels of restrictions were lifted by about June of 2020, and then that's when we started to see this huge peak again, and then slower over time as masks were introduced, vaccines were introduced. They started to see this coming down of their first peak of COVID-19 infections. And so given this application of these different levels of lockdown measures, it was pretty clear that there were going to be some groups that were disproportionately affected by the consequences both of COVID-19, but also indirectly through the consequences of these public health restriction measures. And of course, young people, youth in South Africa, were a key population of concern. So youth aged 15 to 24 comprise about 37% of the South African population, much higher than they do in a country like ours. But they are also much more likely to live in extended family dwellings, so grandparents and young people living in the same setting, and also low-income households. But we really didn't know much about what was happening or what was going to happen to young people as a result of these measures. And so this is where we initiated the AYAZAZI Rights study in collaboration with research partners at the South African Medical Research Council, at the Match Research Unit in Durban, as well as the Perinatal HIV Research Unit in South Africa, in Soweto, my apologies. And so as a team, we connected with local policymakers to ask them, what is the data that you're going to need to inform your work now and in a post-pandemic recovery time? And so we had these 3 objectives: to address knowledge gaps concerning youth experiences of COVID-19 responses and impacts on priority health outcomes. But we also wanted to measure very specifically youth experiences of the containment measures and government responses. So we wanted to look not only at the health outcomes, but experiences of economic hardship, food insecurity, job loss, and look at these questions with a gendered analysis. And then finally, to assess the impacts of the measures on key health outcomes, including sexual and reproductive health outcomes and mental health. And so we launched the AYAZAZI Rights study in eThekwini district in KwaZulu-Natal province. So eThekwini district includes the city of Durban, as well as the surrounding townships in and around Durban. So it's a largely urbanized area, but it does move into what I'd call kind of a semi-rural area as well. And the study design was a cross-sectional mobile health survey. So we programmed the survey to be completed on a mobile phone and partnered with a local company called Moya Messenger, where youth could access the survey for free through this Moya Messenger system to get access to Wi-Fi to complete the survey. The inclusion criteria was youth aged 16 to 24 years of age living in this district. And we engaged in active recruitment of youth from the period December 21st, 2021 to May 31st, 2022. And we used a series of recruitment strategies to identify youth to participate, including contacting youth that had participated in other studies and who had consented to be recontacted. We distributed flyers with QR codes at areas where we knew young people hang out. We sent the link to a number of Durban universities and colleges and high schools and asked them to circulate it through their networks and listservs, of course, via social media, and then where possible, some in-person recruitment. And the survey was, because it was done through mobile data collection, it was self-administered, and it was available in English as well as isiZulu, which is the most commonly spoken language in and around KwaZulu-Natal province. And so over that period of time, I guess that's just under 6 months, we recruited 2,095 young people into the study. And here I just wanted to overlay for you, this is an epi curve showing that in the blue bars, the number of daily cases of COVID-19. This is across South Africa. And then that orange line shows us the cumulative case count over time. And then down here, you can see the timeline. And I just wanted to overlay our study data collection time over what the pandemic looked like. And so you can see this really distinct waves in the South African epidemic. So original wild type virus wave, the beta variant wave, the Delta variant wave, the Omicron variant wave. And then we collected our data just as the Omicron was coming down in terms of case counts. So we were really asking young people to reflect on their experiences over quite a long period of time, to be honest, but over what was quite a high intense time for COVID incidents. And so just a bit of the sociodemographics of who we recruited into the study. So median age was 22 with an IQR of 19 to 24, slightly older given our target was 16 to 24. But then by gender, we identified, this was by self-identified gender, so boy or man was 42%, girl or woman was 53%, and then 5% of the participants identifying as gender diverse. And then you can see the breakdown here by sex as well. We were really happy to have been able to recruit young men and gender diverse people into the study because we found that that's a little bit of a harder group to recruit in our studies in this area. And then we also asked a number of other sociodemographic questions to be able to look at questions around sexual orientation and ethnicity as part of an equity-oriented analysis for the rest of the work that we were doing. And I think importantly, we wanted to see that we had recruited a sample that reflected, generally speaking, what was happening among youth populations in eThekwini district. So in terms of already being parents, we had over a third had at least one child. 30% who were not in school or unemployed, and that is a big concern in eThekwini district. A slightly more educated sample than we might have expected, including 39% who had a post-high school education, but likely reflecting our recruitment strategies. And then 50% with an income of less than 1,600 Rand per month, which is about 116 Canadian dollars, and certainly on the lower side of income. So just to say, we have a number of analyses underway as a study, which has been really exciting for a chance to look at these data in the different ways that we're finding consistent findings, and then sometimes some things that are a little bit harder to understand. But given that it's Pride Month, I thought I wanted to focus here on some of the analyses that we have undertaken that looked at gender and sexual orientation in experiences of intimate partner violence. And then a kind of related next step analysis that we've been undertaking that tries to do a causal inference analysis to look at what is it, could we identify that the experiences of economic hardship exacerbated through COVID-19 restrictions and its role on furthering perpetration of intimate partner violence. So for the next few minutes, I think I'm just going to look at you, Stephanie. I'm assuming that I have 20 minutes. Is that accurate?
Yeah, I was hoping to leave a couple of minutes for questions, but
Perfect.
12:15 now. So
okay. Yeah, that's perfect. Okay, so let me just take you through a few of these findings. So in this first analysis about gender and sexual orientation with perpetration of intimate partner violence. So it's really difficult for me to overstate how prevalent, pervasive intimate partner violence is among young people in South African setting. About 1 in 4 ever partnered women will experience some form of IPV in their lifetime. And these experiences begin young. And so documenting and understanding the experiences of IPV as a survivor and a perpetrator in this age group is a priority in the South African context. And there is evidence that suggests that that perpetration and experiences of IPV are quite common among LGBTQ plus youth relationships, but there's very limited data on this front. And because we had quite a large sample size and a lot of diversity in terms of gender and sexual orientation, we took this as an opportunity to start to examine what some of those experiences might have been. And so I'll just say that in South Africa, it's known as having a quite progressive LGBTQ plus rights agenda for the African continent, as in gay marriage has been legalized for decades, but there is still extensive stigma and violence directed at these populations, and a real lack of there's a real invisibility of youth populations who identify as LGBTQ plus. And so we wanted to carefully, in collaboration with community partners, take a look at these questions. And so that is what we did in this analysis. So I'll just say that the measures that we use to assess physical IPV and experience and perpetration reads like this: has your partner ever slapped you, hit you, kicked you, thrown things at you, or done anything else to physically hurt you? Yes or no? And then we looked at this by sexual orientation and gender identity. So, and then ran some descriptive analyses and then some adjusted logistic regressions. So I'll just show you, sorry to flip through this, but I really just want to show you that a very interesting part of what we wanted to look at is not just to look at men versus women, which is one way that we always try to look at IPV, but really starting to break this down a little bit more of an intersectional lens on intimate partner violence, where we were really able to start to see that the experiences of intimate partner violence during the pandemic were really quite high among gay, bisexual, and questioning men, and as well as among lesbian, gay, bisexual, questioning women, and gender nonconforming youth. And so this just started to tease out a little bit about what the prevalence might look like among these different groups. And as well, when we looked at perpetration, we also saw a reasonably high prevalence of perpetration across each of these groups. And then a question about whether these experiences had changed during COVID-19. And so overall, we saw that 56.6% of youth said that their experiences of physical intimate partner violence had increased or stayed the same during COVID compared to before COVID, whereas 43% reported that their experiences decreased. And we really hypothesized that that was related to the fact, partly related to the lockdowns in some sense. These are young people who commonly do not live in the same household as their partners. And so this was a really different finding than we saw among older adults, where being locked down at home with your partner, particularly for many married women, increased the risk and consequences of intimate partner violence. But again, in this analysis, you can see that it really differed by sexual orientation and gender identity. So in our regression analyses, we also saw this same pattern, right? That we were seeing that there were higher odds of both experiencing and perpetrating physical IPV when we started to look at it by sexual orientation and identity. So I do just want to share with you one last finding about economic hardship and perpetration. So the question, of course, is always like, what is the pathway? What is the pathway that is generating these increased risks of IPV? And in this analysis using causal inference, we wanted to look at whether economic hardship was a causal factor in the pathway towards perpetrating IPV among young men. And the analysis really helped us bring forward that, yes, we did really see that the hardships associated with loss of income and loss of access to a reliable source of food was associated with a 57% higher odds of perpetrating IPV among young men. And so these findings collectively, I'll just share with you, really helped us highlight that the lockdown measures across South Africa, of course, did not affect all groups equally, but the consequences for young people in terms of the dynamics of where they live, what their job opportunities are, what kind of autonomy they have in their own relationships, appeared to be, number one, quite different than the patterns that we were seeing among older people, and had a number of other layers of inequity in terms of how how poor health outcomes and risks such as intimate partner violence were distributed, and the effects of COVID-19. And so we learned across the survey that a lot of youth really shared with us that there were indirect consequences of the public health restrictions to protect against COVID-19, but there were also a lot of direct implications. The number of young people that shared in the open text survey about just grief and loss was quite extraordinary. And so if we take a view to a post-pandemic future, we're not going to be able to gloss over the experiences of young people through this time, and the work of building back and acknowledging the loss of that time, and really, I guess, writing course is some really challenging work ahead for policymakers and other stakeholders in youth health and well-being. So on that note, I'm going to just thank our incredible team of investigators, policymakers, and community partners, and to thank the funders at CICH for supporting us with this funding at the right time. And I'll stop there. Thank you.
Yeah, thank you, Angela. That was great. Really interesting presentation. I'm looking forward to seeing the results all the results that you were able to get from the survey. I think just because of time, I'll just do one question. Maggie left a question in the chat, so maybe I'll just let her ask that, and then we'll move on to the next presentation.
Oh, okay. Yeah, I was just wondering, did you see if there was any overlap between, like, with people who answered both yes to experience and perpetrating IPV?
Yeah.
And did you, like, was there any difference within the different population groups that you were looking at?
Yeah, what a great question. So yes, there was a fair bit of overlap. So kind of violence within the relationship between the groups, and that the proportion of that overlap was a bit higher among gender non-conforming and lesbian, bisexual, and gay women. That those groups seem to have a higher level of overlap between experiences and perpetration. But our numbers started to get a bit small, so our estimates are a bit unreliable. But yeah, we did talk about that as a kind of sensitivity analysis.
Yeah, that's really interesting. And I'm sorry if I missed this, but do you have any of these indicators surveyed before the pandemic?
No, we don't. It's a new. So the only thing that we can do is compare to like historical estimates, and we asked and to ask people to reflect, ask young people to reflect on, did this change from before the pandemic to now? So it's really their own assessment of what that change might be.
Thank you.
Yeah, great questions. Tricky with the mobile survey platform.
Okay, so I'll move on to the next talk. Dr. Liisa Holsti is an occupational therapist, professor in occupational science and occupational therapy at UBC, and investigator at the BC Children's Health Research Institute. Her research program focuses on developing ways to assess and support optimal development in high-risk infants and children. And this includes OptiDev, which is a tool for assessing neurodevelopment in the resource context that she developed. So that's what she'll be talking about today. And on to you, Liisa.
Thank you. Okay, thanks everybody. Really glad to be here, grateful. So today I'm going to talk to you about developing, and we're still in process, developing a culturally appropriate e-tool to assess neurodevelopment in infants and children who have been admitted to hospital for sepsis. I too want to acknowledge that I live as an uninvited guest on the traditional, occupied, ancestral, and unceded territory of the Musqueam people. And I'd like to pay my respects to all First Nations people and acknowledge elders past and present, and also acknowledge my current sources of funding. So I'm here to talk about the OptiDev as one person who is supported by a fantastic group of people who are named on the slides. Dr. Mark Ansermino, who is here, is the co-PI. Matthew Weens, Bella Wang, and Jeffrey Bone are co-investigators, and this couldn't be possible. This would not be possible without our collaborator, Liisa Holsti, who's a pediatrician at Harvard, and Dustin, Peter, Rose, and Maclean, who are helping us with data collection, setting up the data collection system, and then also doing the on-the-ground data collection. So thank you very much to these folks. So many of you will know that pediatric sepsis is a high incidence issue in the world. 4 million children suffer from it, and that those who are living in low and middle income countries have higher rates of sepsis than those in developed countries. Fortunately, with improved treatment, 80 to 85% of infants and children will survive. However, we're learning with more research on morbidity that a third will be left with delays or permanent deficits in neurodevelopment. And the Save the Children campaign has ranked Uganda as one of the 40 worst countries for a child to have a healthy, safe, and secure childhood. And a survey that was done there in 2016 shows that over 35% of those children 3 to 5 years will have a neurodevelopmental delay. And although we don't know directly whether that's related to sepsis, because of the high rate of sepsis, it probably is implicated in some of these delays. So I was approached in the hallway at a conference by Mark, who asked if I knew anybody who could develop a neurodevelopmental screening tool, because they were working with their Smart Discharge program, which has really been led beautifully by Matthew Weens. And the purpose of this discharge program is to reduce hospital mortality and morbidity in Uganda, and I believe currently has 26 sites involved in their studies. And it's a simple mobile app that identifies vulnerable children, and the children and their families receive a discharge kit with a number of resources for them. And follow-up information post-hospital discharge has found that this program has been incredibly effective and reducing death by 30%. However, the need that Mark talked to me about was that there's currently no way to follow up the neurodevelopmental status of these children after they've been discharged from hospital. And so could we try to figure out how to do that in a systematic way? And when we looked into it, we discovered that there actually is no culturally appropriate, easy to use neurodevelopmental screening tool for children up to 5 years. And the key here is 5 years of age. There are screening tools for younger children, but not up to school age. And in particular, ones that are available for frontline healthcare providers who may have very limited training in neurodevelopment. And so the objectives that we had were to design and test the initial psychometric properties of the OptiDev e-screening tool. And the tool is designed for children from 0 to 5 years. The goal will be to seamlessly integrate this into the Smart Discharges program, and the tool is going to be tablet-based. So when I started working with a colleague, an OT, who was doing her master's in public health, and the two of us used 3 key sources to decide what items to include in a screening tool that would fit the environment in which we wanted to implement it. We started with the Malawi Developmental Assessment Tool as our primary source, and we got permission from Melissa Gladstone, who's in England, to adapt the tool, which she has very well developed. But it is a tool that is long and it has 136 items. It is culturally appropriate for children in rural Africa, and it does go up to 6 years. The limitations are, though, that it requires extensive training, takes a long time to administer, and like many developmental tests developed in Western countries, it has specific props or equipment often which can get lost or are expensive to replace. We also use the evidence-based milestone ages framework, and what that does is allow us to screen for skills that occur in a very easy and rapid way that will help us identify potential areas of delay and deficits. And then the final reference we used was the Mix6, and it's a comprehensive health screening tool that collects data on household conditions as well as health outcomes, largely through questioning families about their children's situation and their home environments. So what we did with those three tools was combine the best of the best from those and develop the OptiDev. And the purpose or the way that this is administered is through direct observation or through parent report. We do not need equipment or props, which is a huge advantage. The tool covers gross motor, fine motor, social language, and adaptive skills. And I've just listed two items, sample items. So someone at 6 months, you can observe whether the infant holds and shakes an object. And at 18 months, if you're asking about fine motor skills and feeding, you can ask about how the child does that in a culturally appropriate way. The testing that we have started is occurring in Uganda, and we got grant and personnel support from the Institute for Global Health. I had to go through all my slides and change the names, so I hope I've got them all right here today. And we've partnered with, as I said, Liisa Holsti, who is an investigator at Harvard, and she has had money to collect data prospectively on 600 mothers and infants, looking at biological factors that are related to HIV. She wants to do longitudinal follow-up to 5 years. And what we're doing is we are administering what is considered in developed countries as the gold standard of infant and child development, which is the Bayley scales of infant development. And along with that, at the same time, we are administering the OptiDev items to all infants beginning at 3 months. And when we started this, we thought we'd be able to test 250 children, but even with COVID, we've been able to stretch our money, and we will be able to complete testing on 600 infants between 3 and 24 months. So that is fantastic. So what are we going to do with the data? We're going to start our analysis looking at 3 different things. We want to know how well the items work together. So we will use Chromax Alpha and Omega to look at those. And we will throw out or add items depending on what we find with that analysis. We want to know whether our tool compares well with the Bayley scales of infant development. And we'll look at that using correlation and Kendall's tau statistics. And we will also look at the reliability of the tool and to check the consistency across age and sex. I should have said on that slide, my mistake. So I have some preliminary data I can share with you today on how well the OptiDev works with the Bayley scales of infant development. So this is what we call concurrent validity. And here we have the sample of 500 children from 3 to 24 months. So it's almost the complete sample, but not quite. And with the full sample across all items, we have very good correlation coefficients between the 2 scales. And then divided by sex, we continue to have high correlations, both for male and female children. So at the moment, and I don't want to get too excited because I like to have all my data in before I make any sweeping statements, it appears as though we have strong concurrent validity between the OptiDev and the Bayley in children aged 0 to 2 years. So we almost have complete data from 3 to 24 months. We've submitted a new grant to begin testing older children through the Thrasher Foundation, and we hope to hear any day about that. And I have a physician coming from Nigeria in September who's going to help us complete the analytics and publishing of this first phase of the data analysis, and hopefully also be involved if we can start testing children above the age of 2. And long-term, what we want to do is leverage the foundational data that we've had to get grant funding to continue validating the tool up to 5 years, and we've started doing that through the Thrasher Foundation. We want to modify the OptiDev items for use in other LMICs so that the language is culturally appropriate and the tasks that we're asking are culturally appropriate. Eventually, we would like to develop simple early neurodevelopmental intervention materials to be able to provide families once they've had an assessment, and to work with our partners in hospitals and in governments to expand treatment services for children, first in Uganda and then to other LMICs. And I think that that is it. So I'd be happy to take a question or two if there are any.
There's nothing in the chat, but if anyone has a question, feel free to unmute yourself and go ahead. Otherwise, I can start things off. Actually, I had a question. I was wondering actually, what are the current, current services available for neurodevelopment support for children in Uganda right now? I feel like I should know this, but I don't. No,
and I think Bella's on the call and probably knows better than I do. They're quite limited. They tend to be in larger centers, and really, there's lots that needs to happen. There's a shortage of rehabilitation personnel to be able to assess and deliver the services. There's a limited number of tools that are available. There are limited numbers of services. So and there's limited research. So there's really, we're starting at the beginning of a very long process that it's going to require a multi-pronged approach to get adequate services for all the children. And so the development of a screening tool, it presents us with an ethical issue. What do you do if you find something? Then what are you going to do with the children? We can refer a limited number for more rehabilitation kinds of assessments, more detailed assessments. But at the time that we're developing the tools, we also have to advocate for appropriate training. And I don't mean task shifting. I mean getting a new pool of people who actually are trained to assess and treat neurodevelopmental difficulties in children. More OTs, more PTs, speech language, audiology. It runs the whole gamut of rehab folks who they just need more of. And so today's presentation is just a very small piece of a large and long road to walk here.
Thank you. I mean, yeah, it sounds like lots of challenges, but also lots of ways we can make progress. It's exciting.
Do we know the time scale for becoming a parent? And then fairly soon. That's a great question. Is it Becky? I hope I've got that right. There is some data that shows that the children kind of slowly recover over a couple of months. But we do have some data from Western countries that show that even after a year, the children have not recovered to their baseline function. And that's in a developed country. So I think that we have a lot to learn still. And that's part of the reason for having the Smart Discharges program and providing a more comprehensive morbidity follow-up post-discharge. Thanks, Alexis. Appreciate your support.
Any other, or we have time for maybe one more question, but if not, I'll go to the next presentation. Okay, great. Thank you, Liisa. That was, really interesting. Looking forward to continued work with OptiDev.
Thanks.
So the last speaker is Maggie Kinshella. She's a global health research coordinator with the UBC Preempt team and also a PhD candidate with the Women Plus and Children's Health Sciences program at UBC, where her research is looking at maternal diets in sub-Saharan Africa and pregnancy hypertension. So she works on numerous global health projects around the world, as well as rural and remote health projects in Canada. And this includes projects in Botswana and Malawi, which are led by Dr. David Goldfarb. And that's what she'll be talking about today. Go ahead, Maggie.
Great, thank you. And you can see my slides.
Yeah, good.
Okay, everything looks good. Okay, so thank you for the introduction, Stephanie. And on behalf of the team and Dr. David Goldfarb, thank you to IGH and everyone for this opportunity to talk about this project, saline gargle sample collection for COVID-19 testing in Botswana. So just first, I wanted to share that I'm currently calling in from Ladner, BC, the land of the Tsawwassen, Musqueam, and Stolu First Nations. I feel very privileged to work and play from the traditional, ancestral, and unceded territories of the Coast Salish peoples. So first, I'll just give a little bit of background on the project. So the WHO reports over 7.5 million confirmed cases of COVID-19 globally, which equates to about 1 in every 10 people. There have been almost 7 million deaths worldwide, including 175,000 confirmed COVID-19 deaths in sub-Saharan Africa. So the WHO announced on May 4th of this year that the COVID-19 pandemic is no longer a global emergency. It still continues to be a threat to health worldwide. And I found this really amazing or staggering that over 200,000 new confirmed cases were reported to the WHO in the first week of June itself. So this really highlights the importance of continued COVID-19 testing. So effective pandemic response relies on effective testing to manage patient care on an individual level and inform public health policies on a population level. The gold standard for COVID-19 diagnosis was a nasopharyngeal MP swab, flock swab collection from the upper respiratory tract performed by a trained healthcare provider using nucleic acid amplification testing to detect any potential viral material. However, with increased demands for testing and high sample collection volumes, MP swabs proved to be a critical bottleneck. Challenges included swab shortages and their expensiveness, shortages of healthcare providers, and personal protective equipment needed to collect the swab samples, as well as patient discomfort. The invasiveness and the discomfort of swab collection was a challenge, especially for children and people undergoing frequent testing. So just want to briefly discuss here that MP swabs are generally safe, but not entirely without risk, especially for pediatric populations. So there has been documented reports of retained swabs, bleeding from the nose, and cerebrospinal fluid leakage due to MP swabs with COVID-19 testing. So to address these challenges with MP swabs, several groups looked into developing alternative sample collection methods. And gargle sampling was one that emerged. Gargle sampling involves rinsing and gargling a small volume of liquid, which would then be processed and tested for COVID-19 with no extra steps in comparison to MP swabs. As you can imagine, it's less invasive and less uncomfortable than MP swabs, making it more acceptable for users. And it's a simple procedure that can be performed by children with proper guidance. And it also has potential for effective self-collection, which reduces the need for specialized healthcare professionals to administer collection, and subsequently can help reduce the healthcare resource burden. So the saline gargle sampling method was pioneered in British Columbia, Canada, as an important alternative sample collection method, particularly for school-aged children. It became widely implemented as an option in BC and has been since implemented around the world. So our project really asked, what about in a low and middle income country setting in sub-Saharan Africa? So our work in Botswana, which is a landlocked country in Southern Africa, is in collaboration with the Botswana-Harvard Partnership, and really aim to support implementation of gargle sampling as a sample collection method for COVID-19 testing in Botswana. So our project compiled evidence and built capacity for scale up in Botswana, with a real focus on objectives being site-driven and emphasizing capacity building through collaboration between trainees in Canada and Botswana. Through our discussion with stakeholders in Botswana, they really expressed a need for evidence-based recommendations grounded in the local context. And they identified this as a requirement of before scale up of saline gargle sample collection in their health facilities. So consequently, a systematic review evaluating the performance of self-collected gargle samples compared to swab collection for COVID-19 test was undertaken by a Canadian master's student, and clinical validation of saline gargle was led by a master's student in Botswana. So I will now briefly share some of those results from those activities. So regarding the review, the information on the methodology is listed here, but just very in brief, that we searched several online databases and preprint servers. Results were screened in a two-stage process by two independent reviewers against an eligibility criteria, and data was extracted from the included studies and pooled using random effects meta-analysis in RStudio. So the two outcomes of interest were overall gargle sensitivity and the mean difference in sensitivity between gargle and swab methods. So we were really interested in sensitivity, which indicates the ability of a sample type to correctly detect the viral material in relation to a reference standard, which was any positive SARS-CoV-2 detection by either swab or gargle methods, recognizing that even though MP swabs is the gold standard, it is not perfect. So the searchers identified 313 search results, and after study screening and removal of duplicates, a total of 24 studies were included. And meta-analyses pooled 28 gargle swab comparisons. So interestingly, studies were included studies were conducted across North America, Asia, and Europe, but there were no studies from the African continent, which highlighted the importance to explore gargle sampling collection method in this local context. And just also to mention that studies covered a diversity of study populations and variations within swab and gargle collection methods. So we found an overall sample sensitivity of 92%, or almost 93%, which was only 3.2% less than any swabs. And the overall gargle sample sensitivity across the different studies range from 81 to 100%. And looking at the different study characteristics, just wanted to highlight here that overall performance was high. It was pooled outcomes were over 90% sensitivity across the different sample study populations and different swab and gargle collection methods. And we're only a few percentage points below a swab method across all subgroups explored. And then switching over to the validation study in Botswana. So we evaluated the saline gargle method against MP and OP swab method in the molecular detection of SARS-CoV-2 in Botswana. Participants were recruited from an outpatient COVID-19 testing facility in Gaborone, the capital city in Botswana, between December 2021 and September 2022. So we really captured kind of the wave, the Omicron wave with that. And participants provided both a swab and saline gargle sample. So the validation study recruited 129 participants, which resulted in 25 matched samples that tested positive for COVID. In our validation study, we found that saline gargle had a sensitivity of 81%. And first-hand experience from our study found that participants, like in the literature, favored saline gargle and reported that it was less painful than swabs. Also very interestingly, we were able to successfully perform next generation sequencing on 10 laboratory confirmed COVID-19 positive samples, saline gargle samples, in addition to 6 positive swab samples. And sequencing of the swab and gargle matched samples found similar evidence of the Omicron variant. And that so saline gargle sampling can promote routine sequencing, which can lead to more rapid response to novel strains and can hopefully strengthen public health interventions as well. So now to turn to the implementation. So based on discussions of investigators and stakeholders from Botswana, the pediatrics ward in Princess Marina Hospital, the tertiary facility in Gaborone, was discussed as an ideal place to start because saline gargle is a more child-friendly approach, and that some of the healthcare providers had reported difficulties and resistance of MP swab collections with children, which makes it more difficult to accomplish, as well as potentially compromises testing accuracy. So in our support for Scale Up, we're currently finalizing the review and the validation study manuscripts for publication, which were 2 pieces of evidence that the stakeholders had requested. We've also developed a policy brief, an infographic on saline gargle for COVID-19 testing in Botswana, and compiled kind of information on saline gargle from utilization in Canada for use in Botswana. And this is to make a bit of an info package to provide to hospital administrators and other stakeholders as they're deciding on whether to adopt saline gargle as a method. And we're hoping to schedule some meetings with hospital administrators within the next few weeks, and pending if they approve, start implementing saline gargle at the pediatrics ward in Princess Marina. Will be training staff at pediatric morning rounds. And then our proposed monitoring and evaluation of implementation includes kind of stock checks of how many saline gargles was used, and then also informal post-implementation conversations with staff in the wards about their experiences, which is to be compiled in a report. And we've also talked about some next steps, some discussion with colleagues in Uganda regarding potential evaluation there, and also a plan for testing samples for other respiratory pathogens. And I just wanted to talk a little bit, very briefly, about how testing is foundational, and investing in these new methods helps to build resilient health systems in Africa. So as I briefly mentioned in the beginning, the WHO announced on May 4th that COVID-19 was no longer a global emergency, though it still acknowledged its pandemic status as a threat to health around the world. So moving beyond this emergency phase of the pandemic, continued COVID-19 testing is critical for surveillance, even though it might be challenged by lower prioritization. So this really underlies the importance of acceptable methods of sample collection and building resilience into healthcare systems to deliver appropriate care, monitor vaccine effectiveness and new strains, and be prepared for future outbreaks. From the BHP laboratory that we're working with, which is very inspiring as the lab that first sequenced the Omicron variant in routine surveillance, Dr. Moyo highlights the intentional strengthening of infrastructure and collaboration across Southern African region to detect and respond to infectious diseases in resource-limited contexts. And that strengthening diagnostics and validating innovative sample collection methods in low and middle income countries is an important part of that process. So just want to underline here that sample collection is foundational to COVID-19 testing, which is needed for everything else in the pandemic response. Okay, so I'll end there. Thank you very much for the opportunity to share about our project, and I'll open it up to questions.
Again, thank you, Maggie. That was, yeah, very, very excellent note to end it on. I think Mark has his hand up. Is that for?
Yeah, Maggie, really amazing stuff, and congratulations. I just want to ask, what is the youngest age that you can do these gargles at? And would it be practical to perhaps do this without necessarily gargling, but just taking a oral swab, like a buccal swab or something like that?
So I can answer the first part of that question, and then I'll turn the second part of that question probably to Dr. David Goldfarb, who can respond more accurately, comprehensively to that. But as far as age, the systematic review found that it was possible as young as 4 years old. I think that they just need to think about, to know how to gargle. The saline, it varies a little bit, I think, depending on the liquid that's being used. The saline is quite salty, so they're more likely to spit it out. But some have also tried using water, which, if you imagine in a resource-limited setting, a bottle of water is widely available for use. But I think one of those challenges is, like with young children, to get them to swish and spit it out rather than just drink a bit of liquid. But regarding the second question, David, did you want to jump in on that part there?
Sure. So people have looked at various swabbing, basically every orifice when it comes to COVID. And oral swabs, at best anterior. There was actually a study, we were one of the sites evaluating those, but there's many sites evaluated that. Unfortunately, you lose quite a bit of yield, and that's also when we looked at gargle, and Irina looked at that as well in her review. If they don't do gargling, because gargling actually gets at basically where we get at with a nasopharyngeal swab, which is right at the pharynx, at the very back of your mouth. And so if it's just the anterior mouth, we don't tend to find as much yield, and particularly oral swabs are usually maybe 50% or less sensitivity compared to samples that go at either the nasopharynx or the oropharynx at the back of the throat, and similar gargles. So it is challenging with peds when we get to young patients. We did do an evaluation here at Children's, though, with self-collected bilateral nasal and oral swabs that parents collected in younger kids, and that does seem promising. So that may be an easier sample for the very young children.
Thank you for your questions, Mark.
Yes, thank you. Thank you for the speakers, and thank you all for attending. And actually, I should have mentioned at the beginning, but thank you to the Children's Hospital Foundation, who has been able to support these Global Health Seed grants. So actually, Dave and Maggie's project and Angela was from our first round a few years ago, but we've been able to support a few more projects over the years, and I think we'll be able to do hopefully another round in the fall. So stay tuned for that. And yeah, thank you, and have a good rest of your day.